Good day, my name is Dr. Simon Marr from Melbourne, Australia. Today I'll be talking about first trimester fetal brain malformation, what every clinician needs to know. The talk's divided into the following sections: an introduction, the normal brain anatomy and ISIO guidelines. The centre of the talk I'll be talking about the varied and sonographic appearances of these abnormalities, and then finishing up with some summary and comments and some take-home messages. If you look at brain malformation, it can be divided into always, sometimes, and never. And you see the never group is quite a large, lengthy list. But the fact of the matter is 2/3 of brain malformation occur across these two groups. Let me repeat that. 2/3 of major brain malformation may be detected in the first trimester of pregnancy. In fact, it's the organ system with the highest yield of detecting malformation early in pregnancy. The ISIO guidelines are divided into a basic assessment of the brain to the detailed assessment of the brain. If you want to detect 2/3, you really look to need the detailed assessment. These are the landmarks listed in the ISIO guidelines in a detailed assessment, and there are two key planes: one, sagittal, and two, axial. When you look in the sagittal assessment of the brain, you're looking for the landmarks of the brainstem, which is the largest, the fourth ventricle, intracranial translucency, intermediate, and the smallest black space here is the cisterna magna. Important to observe all of these. Then move on to the axial assessment, look at the midline falx, the lateral ventricles, the choroids, which are frequently irregular posteriorly, the cavum velum interpositum, the aqueduct of Sylvius, and the cerebral fourth ventricle lined by the echogenic bar of tissue called the choroid. When you look at these four sections, you also appreciate the calvarium is ossified and well formed. If you apply looking at these two sections, you will identify the majority of abnormalities, starting with one, acrania. When you look at this fetus, you can see a thin nuchal translucency. The untrained eye may see a normal-looking fetus, measure the crown rump length, and go home, and may not appreciate the brain is irregular in outline. However, if you go through a four-segment axial assessment, it's an impossible diagnosis to miss. None of the landmarks I've mentioned in the previous slide are evident in this fetus. This is acrania. There's no calvarium bone, no midline falx, no lateral ventricles, no choroids, no fourth ventricle. These landmarks are all absent. So I encourage both axial and sagittal imaging in the first trimester of pregnancy, and it'll yield a 100% detection rate. If you actually look at the published literature, the detection rate is not 100%. You ask why? Because there are varied appearances. Can have a bilobular appearance, foreshortened, elongated, cystic, overhanging, and irregular. And we reported this back in 2018, and matching these images with sonographic appearances of bilobular, foreshortened, elongated, cystic, and then the overhanging brain that mimics an encephalocele, and then this one here, an irregular brain. So depending where you are along the pathway of brain degradation depends on what the sonographic appearances are. And it's important to recognize these subtypes. In doing so, it'll allow you to reach a detection rate closer to 100%. Also bear in mind, a significant proportion of fetuses in the fourth section will demonstrate a dilated cerebral fourth ventricle in the setting of acrania. When you see that, bear in mind that this is far more likely to be related to a chromosomal abnormality than being an isolated neural tube defect. And it's important in these groups where patients choose not to continue the pregnancy, which is most, to consider a postabortal karyotype or microarray, because you will find the common aneuploidy or digonic triploidy as the causative factor behind the acrania, which has implications in counseling the patients. Then as we move forward into the new era, before 11 weeks of gestation, when we draw in a blood for cell-free DNA, we can appreciate acrania even early in the pregnancy. However, this is beyond the brief of my talk today, but something that in the future we'll be looking to detecting earlier in pregnancy. There's the cephalocele. These are challenging. We reported the largest series of 35 back in 2015, recognizing that over 70% of these are occipital. Bear in mind, if you do see the parietal, which is about 10% of them, you need to consider amniotic band syndrome or the disruptive syndromes. And also bear in mind that about 10% of these are related to Meckel-Gruber syndrome. So while all of you think that it's a pretty straightforward diagnosis, in most cases it's either isolated or with trisomy 13, 18 or digonic triploidy, there are in fact exceptions to these rules. And I'll walk through them: the Meckel-Gruber, the disruptive syndromes, and then the minor cephaloceles, which may progress to a major abnormality, and vice versa. So cephaloceles are not as easy and straightforward in the first trimester as advertised in textbooks. Let me walk you through them. You go to work tomorrow morning, you see a reduction in the frontal maxillary facial angle, thin nuchal translucency. But as you look through the occipital bone, you see there's a defect with the aqueduct of Sylvius and the midbrain and brainstem herniating through an occipital defect, a classic encephalocele. Far more striking when you look vaginally because you see this solid cystic mass. This is not an increased nuchal translucency. Atypical encephalocele at 12 weeks and 5 days. You can add 3D to it, in a sense the diagnosis is made on 2D, but a patient will understand this image more than anything else you show them. So this is a 3D surface rendered of a typical posterior encephalocele at 13 weeks of gestation. But it's important to recognize that when you see an encephalocele, is go the next step. Ask yourself, is there anything else going on? Thin nuchal translucency, cystic kidneys, polydactyly, and cystic kidneys on an axial section. In this case, you will find a negative chromosomal microarray, and then this will lead you down investigating, look for monogenic disorders such as Meckler-Gruber syndrome. And this will be exon sequencing, and it's so important, therefore, to make the diagnosis in early in pregnancy so you get the result of your monogenic studies before 20 weeks of gestation. And then there's this group where you see a very obvious encephalocele at 13 weeks and 5 days, but when you turn up the gain on the ultrasound system, you then see multiple bands extending from the coelomic space to the fetal head. This is amniotic band syndrome as a causative factor of the encephalocele, not aneuploidy, not Meckler-Gruber, and important because the recurrence risk is much lower in the setting of amniotic band than any of the above mentioned. Then there's the group where you see at 10 weeks and 6 days where you see the encephalocele where you've got herniation of the midbrain and brainstem through a defect in the occipital membrane very early in the pregnancy at 10 weeks and 6 days of gestation. In the same fetus, when you bring back at the mid-trimester, 22 weeks, I'm jumping to the MRI, showing a normal posterior cranial fossa, and you have this echogenic area in the region of the straight sinus and a tiny little cystic mass in the occipital region. So this is an example of a cephalocele that regressed. On the flip side of the coin, this is a cephalocele that progressed, presenting initially as a tiny meningocele, no neural tissue, normal landmarks, normal brainstem, normal intracranial translucency, and cisterna magna. When you look at the same patient 2 weeks later, 2/3 of the brain is herniated through the occipital defect, an example of progression. A slightly different form of progression is a fetus at 14 weeks who had a cystic mass with neural elements central in it. And when we look to the posterior cranial fossa, we could see normal landmarks on our 4-section analysis, a normal aqueduct, normal cerebral fourth ventricle, normal cerebellum, and the normal choroid bar. Bringing the patient back 4 weeks later, however, we see a very different picture with severe ventriculomegaly, which was simply not evident at the 14-week scan. So things may change over time with the cephaloceles. And then lastly, there is the group where you have entirely normal brain structures, no occipital bone defect, but a cystic lesion in the region of the occipital bone, no connection with the central nervous system. And this is an epidermoid cyst. This can be a very challenging diagnosis or differential diagnosis at this early stage in gestation. Also, increasingly, we are seeing encephaloceles before 11 weeks of the pre-NIPT scan, dating scan at 9 to 10 weeks of gestation. Then there's the meningocele. So in these, you will see cystic mass arising from the occipital bone, no neural elements in it. Again, important to go to sagittal evaluation, looking for the brainstem, the intracranial translucency, and the cisterna magna, no neural elements. But again, important to follow these up because they may find later in the pregnancy that the picture changes. Then there's the group of holoprosencephaly. I think this is an easier diagnosis than any of the others I've mentioned before, either acrania or encephaloceles. Why? Because the 3 sonographic markers we have to rely on, absence of the falx, loss of the butterfly sign, and a single anterior monoventricle. So helpful, these landmarks, in making a certain diagnosis. We can only pick up, however, the alobar and semilobar. We are unable to identify lobar HPE in the first trimester, a terrible condition in which 50% of these die within the first 4 months of life. Also, a useful sonographic marker is a reduction in the BPD, which we reported back in 45 cases of HPE back in 2014. It's also a reduction in the BPD that may lead you to diagnosis of open spina bifida and also the diagnosis of encephalocele. So a very useful landmark is the reduction in the BPD. Take it seriously. And then we move on to holoprosencephaly sonographic appearances. Here in this case, absence of the falx, single anterior monoventricle, and sharing of the choroid across the midline. You may use 3D rendered imaging of this, showing you the kissing of the choroids across the midline, but in a sense, it is a 2D diagnosis. Some, however, may be challenging in the first trimester. In this case, the single anterior monoventricle is less obvious. The experienced eye will, however, recognize that there is sharing of the choroids across the midline with loss of the butterfly sign. If you change to a higher frequency transducer, now you can appreciate the choroids, and also you can appreciate the single anterior monoventricle more clearly than with a lower frequency transducer. Then in this case, even early in the pregnancy at a pre-NIPT scan, at 10 weeks of gestation, single anterior monoventricle, core is shared across the midline, and the aqueduct, which at this stage is juxtaposed to the occipital membrane. Using 3D surface rendered imaging on this with a silhouette and transparency, you can appreciate the single anterior monoventricle with the choroids shared across the midline. But again, I say this is a subject for another talk on another day, talking about making diagnosis of these major brain abnormalities before 11 weeks of gestation. Then there's dilatation of the cerebral fourth ventricle or either reduction. Let's start off with dilatation. Aneuploidy, Dandy-Walker, Blake's pouch, Joubert, another genetic syndrome, and remember, may also be a transient finding. Plenty has been reported about the reduction or absence of the intracranial translucency in spina bifida screening, but it's also reduced in encephaloceles. And then finally important to look at the morphology of the fourth ventricle, in particular the roof or the choroid bar, which covers the fluid. Let's start off with a 4-segment analysis of a normal brain: falx, choroid, lateral ventricle. And then look at the very final section here. And as you go from the aqueduct, which is normal, and you come down to the 4 sections, you see a completely normal fourth ventricle. Now compared to this case, falx, choroids, normal, lateral ventricles, normal, cavum velum, normal, aqueduct of Sylvius, normal, distance to the aqueduct of Sylvius, occipital bone, normal, but then you see a very obvious dilatation of the cerebral fourth ventricle. In a sense, I don't really need to measure that. I can see subjectively I have a very obviously dilated cerebral fourth ventricle. So why would the fourth ventricle be increased? Well, let's walk through it. In this case, we have dilatation of the cerebral fourth ventricle in a fetus with a hypoplastic left heart. This was caused by trisomy 18. In fact, over 53% of fetuses with trisomy 18 were presented with a dilated cerebral fourth ventricle. What about this case? Bilateral pleural effusions, fetal tachycardia, shortened long bones, and a dilated cerebral fourth ventricle. This is a fetus with trisomy 13. In fact, 80% of fetuses with trisomy 13 were presented with a dilated cerebral fourth ventricle. What about this case? A dilated cerebral fourth ventricle with a cystic hygroma in a fetus with monosomy X. What about this case? An important one, this one. It looks like macrocephaly, but in fact it's the abdominal circumference that is below the first centile that makes it look like this. And then you have this striking dilatation of the cerebral fourth ventricle on sagittal imaging in a fetus with a thin placenta, typically with a low PAP-A and HCG, all the landmarks pointing towards digonic triploidy, which will frequently have a negative NIPT cell-free DNA result, particularly if you're not using a SNP-based array. This is digonic triploidy. Another case of digonic triploidy, dilated cerebral fourth ventricle. And this case here, slightly different in appearance, that you have dilatation of the fourth ventricle, but there's no choroid visible. And of Valdo Sepulveda, that's reported on the finding of absence of the choroid lining the roof of the fourth ventricle, is a landmark for coexisting brain abnormalities and extra CNS abnormalities. So pay attention to the presence or absence of the choroid. This fetus also have digonic triploidy. So let's say the chromosomal microarray comes back normal. You have a fetus here with a dilated cerebral fourth ventricle and nothing else. What's going on? When you bring the patient back at 20 weeks of gestation, you see all the typical features of Blake's pouch, and fenestration occurs. You have a normal firmus at 31 weeks of gestation. In this case down here, you have dilatation of the cerebral fourth ventricle, but a very different picture to the one above, where you've got absence of the vermis, wide splaying of the cerebellar hemispheres in a fetus with Dandy-Walker malformation and ventriculomegaly. So the above case is the typical appearances of a Blake's pouch. The below case is the typical appearance of Dandy-Walker malformation. But we weren't able to say that at 12 weeks of gestation. It's only by following it through the pregnancy. Are there any clues in the first trimester of pregnancy that allow us to distinguish between Blake's and Dandy-Walker? There's very little data out there. What data there is suggests on a very small case series of 4 that if the aqueduct of Sylvius is absent and the fourth ventricle is dilated and the chromosomal microarray is normal and it's none of the previous differential diagnoses I've mentioned, well then this is more likely to be Dandy-Walker. Whereas if the aqueduct of Sylvius is dilated, as in this case you see an enlarged posterior cranial fossa dilated aqueduct or normal size aqueduct, then it's likely to be a Blake's pouch. So that may be a useful clue in the future, but we need more data to support that. Then there's Joubert syndrome. So let's start off with the axial. These are two separate cases. Start off with this case, 2017. Absence of the vermis, dilated cerebral fourth ventricle, and then that typical sort of molar tooth configuration when looking across the BPD. Very nice paper by Ritsuko Poo recently suggesting looking for the lambda sign. So as you look here, the two key things you're looking for is the communication of the aqueductus sylvius and cerebral fourth ventricle. But you see this downward displacement here of the rhombic lips. They should be in a transverse position like this schematic up here. But instead you get collapse of the rhombic lips towards the midline as demonstrated in this 3D image here in a fetus at 12 weeks and 4 days of gestation, Joubert syndrome. Most important of all, if you are faced with dilatation of the cerebral fourth ventricle, there is a separate group. When you bring the patient back after 13 weeks and 1 day, 3 weeks later, you find the cerebral fourth ventricle has returned to with the normal limits. Chromosomal microarray was normal. So just bear in mind, there is that group of a transient dilatation of the cerebral fourth ventricle. Then before 10 weeks, I keep mentioning that you may identify brain abnormalities before 11 weeks of gestation, but it is a talk for another day. But I do want to highlight that many of these major brain malformations may be identified very early in the pregnancy, and we need more data in terms of deciding how we manage these in the future. But I'm giving you a taster of these. Okay, spina bifida is being addressed later on this morning, but let me say 1 or 2 points about it. About 30% of spina bifidas will be identified by looking at the spine directly. The remainder, we have to rely on the intracranial markers to make these diagnoses. When you look at the intracranial markers, I do want to make one important point. We look at the posterior cranial fossa in the second trimester of pregnancy, but in the first trimester of pregnancy, the more reliable markers on all the published data to date is the midbrain and the brainstem, not the posterior cranial fossa. The original paper by Rabi Shawi reported 100% detection rate on 4 cases based on the posterior fossa looking at the intracranial translucency, but we now know 15 years later that in fact the midbrain and brainstem is in fact where the strongest landmarks or markers which would bring us to the diagnosis for those other 70% where you can't see the defect. Remember, the defect is really quite tiny because the fetus is so small in the first trimester of pregnancy. And that's why over 20 different markers have been described. It tells a story. It's a difficult diagnosis. The second trimester, we rely on a single marker of the banana-shaped cerebellum or the lemon-shaped head thrown in, whereas we've all these markers listed in the second trimester of pregnancy. I would say simplify it and look at 2 things. When you look at what happens in spina bifida, you have posterior and inferior displacement. So instead of having the brainstem, IT, and cisterna magna in descending order, you end up with a large brainstem and obliteration of the cisterna magna and intracranial translucency. But this is only in a certain proportion of cases. The other landmark is the crash sign, which described, it was titled a new sign in 2019, where you get posterior displacement of the midbrain, but it was not new at all. We had actually reported on it 8 years earlier, the exact same sign. And look at this schematic because it tells you exactly what happens in spina bifida. We like this marker because everybody in this room knows what a BPD looks like, where there's a learning curve in understanding all the lines and spaces with the intracranial translucency. Not only did we report it as being the first sign, well before the crash sign, 8 years prior to it, we quantified it. So what we did was we looked by measuring the posterior border of the aqueduct to the inner border of the occipital bone. We were able to tell when the car was at the beginning of the crash, in the middle of the crash, about to crash, and to crash. And we did this through successive pregnancies, looking at the normal distance between the aqueductus sylvius, and we measured this to the inner border of the occipital bone. We do that for every pregnancy. And for over 30 cases of open spina bifida, we have a very high detection rate using this marker. I encourage using this with the sagittal markers I've mentioned, including the intracranial translucency as reported by Rabi. Looking at meningomyelocele, these represent about 80%, and you will detect many of these by looking at the spine directly. Far more challenging is when you look at the myeloceles, about 10 to 15%. You can see this looks completely normal. It's only when the fetus turned over into the spine up position we could appreciate there was a tiny defect just here. And when you look in a coronal section, you can see the exposure of the neural elements of the spinal cord. See how challenging that is. When you move on to a surface rendered image here in the same fetus, you can see the myelocele, the exposure of the neural elements. But this really requires the experienced eyes to detect these. They can be extremely challenging. If you are ever left in a position where you are uncertain about the diagnosis, then bring the patient back until you can make a certain diagnosis. And then there's the last group of the spina bifida, in which the spinal dysraphism, and this is frequently where you have a disruption of the spine, and some of these exist with the OIES complex or either with the trisomy 13s and 18s. Differential diagnosis, remember you may have a cystic mass arising from the sacral bone, and for many of these they are pretty straightforward, but some of them may be challenging. This is solid cystic, and I don't think anybody in the room would confuse this with open spina bifida. Then moving on to hydrocephalus, when we look at this fetus here, we measure the area of the choroid to the area of the lateral ventricle. And we measure these and chart them using the chart by Luero and colleagues. Or you may simply take the distance of the choroid and measure to the distance of the lateral ventricle. Either way, these are the objective assessment, but for most of these, you subjectively appreciate there's ventricular dilatation. Look at this case. The choroid occupies less than 50% of the lateral ventricles. The lateral ventricles are really grossly enlarged. And as you sweep through this, you appreciate the communication of the third through the foramen of Monroe on both sides bilaterally in a fetus with aqueduct stenosis at 12 weeks and 6 days of gestation. We know before the patient comes to see us by cell-free DNA, we will have genitalia because this is typically occurs in a male fetus. Again, the value of having NIPT before we jumping into doing a first trimester scan. Next case is here, same patient, next image showing using 3D with VCI and VRSI, showing the gross dilatation of the lateral ventricles. And you can use the different render modes to outline the lateral ventricles separate from the cranium and separate from the choroids. In this fetus here, dilatation of the lateral ventricles at 13 weeks and 6 days of gestation with bilateral hydrothoraces in the fetus with trisomy 21. In this case here, dilatation of the fetal cerebral lateral ventricles at 13 weeks of gestation, measuring the length of the choroid to the length of the lateral ventricles. This fetus also had choroid plexus cis, so both ventriculomegaly and choroid plexus cis. This was a fetus with agenesis of the corpus callosum. Same patient back at 23 weeks, all the typical landmarks on axial imaging of agenesis of the corpus callosum with a midline cyst and sagittal imaging confirming absence of the corpus callosum. Finally, finishing up with choroid plexus cyst, don't worry about these. They are common in the first trimester of pregnancies. Just check that there's no coexisting markers of trisomy 13, 18, or the other aneuploidies. And if there are no supporting markers of it, these, for most, will disappear as the pregnancy progresses. I have seen some of these over the years appearing as very striking cystic lesions, almost mimicking the appearances of brain tumors. Brain tumors have never been reported in the first trimester of pregnancy. So again, you need to be conservative in managing these going forward. So in summary, brain abnormalities, the majority of these can be detected in the first trimester of pregnancy, and they fall into these two groups of always and sometimes. It's important then going forward tomorrow morning as to how you approach screening and diagnosing the first trimester is looking at sagittal and axial imaging. Look at the brainstem, look at the intracranial translucency, look at the cisterna magna. And if you're going to take one measurement, I would suggest you take the intracranial translucency, not so much as a marker only of spina bifida, but it's a marker of it being dilated, of aneuploidy, posterior fossa anomalies, microdeletions, and so on. It's a very powerful marker, and it's a very powerful marker for digonic triploidy, where it's dilated in over 2/3 of cases. And that's important in a world where we're increasingly using cell-free DNA. And as I mentioned, most of us are not using a SNP-based platform, and the cell-free DNA will be unrevealing. Then on axial imaging, just go through the exercise. Once you've done 100 cases like this on axial imaging, you then get to recognize all these landmarks, and you will become proficient in detecting major brain malformation in the first trimester of pregnancy. Thank you very much for your attention.